So we're delighted you could be here with us, and thank you, Dr. Myint, for being with us too. So we have several population health entities on this campus. We have the Population Health Initiative, that is a cross-campus collaboration of different departments and scientists. We have the Department of Health Systems and Population Health at the University of Washington School of Public Health. And then we have an entire population health office at the University of Washington School of Medicine. And so Mike and I sought each other out about a year ago when I joined to be friends and to talk about population health. So we go on quarterly walks to talk about big population health topics. And so it's my pleasure to be able to have this conversation with you today.
Oh, no, thanks for having me. I just find that having these type of forums and being able to have cross-campus collaborations is one of the, I think, hidden gems that we haven't fully taken advantage of in my time here so far.
And in eras of uncertainty and a tumultuous landscape for science, higher education, for healthcare, I think the antidote and our solutions will be around collaboration. So I thank you for having this conversation. Can you tell me what population health means in your context of work?
You know, I think to start with, I'll describe my role a little bit because I think it'll help contextualize how I'm going to answer that question. My role is as Chief Population Health Officer. It's a new role that was created at UW-Medicine, which is the care delivery wing of University of Washington. It's associated very closely with the School of Medicine, of which I'm faculty, and I'm an infectious disease epidemiologist by training. But this role was created about 3 years ago to really start thinking about how does the healthcare delivery side really think about population health, and we'll talk about value-based care and kind of where the intersection between these are. And so my role was to discover a lot of what's going on, including all these cross-campus potential collaboratives with the Population Health Initiative and other work going on across. And as part of my new role, a newly created role, and I was the first person taking this, I did a 90-day survey of UW-Medicine, School of Medicine, and then several of the other schools around UW-Medicine, including the Population Health Initiative and other programs. And I asked everyone to define what population health meant to them. And what I got was very, a wide variety of lenses on what folks' roles were within population health. Just within UW-Medicine, I found over 50 people with population health in their title, only 2 of which have a dotted line relationship to the Chief Population Health Officer of the group. And it's because I think population health, like quality, like equity, like many others, means a lot of things depending on the context. And so what we've done is try to create a shared common language across the care delivery side, a working definition, not a be-all, end-all definition, but a working definition of population health, which we define really in really a basic way, which is understanding health populations that we serve and wish to serve at UW-Medicine, because we're the care delivery side. When we say serve, it's the patients that we're actively seeing or that we anticipate that we'll see. That we wish to serve is under a lot of lenses. That could be an equity lens, where we feel like we're underserving certain members of the community when we talk about food security or trauma-informed care and violence, breaking violence, like the 2 great talks that we just heard. And so as we look at the differences of those populations, health differences between those populations, then we start to think of drivers of those and interventions we can have. And then I'll just keep going to say that value-based care is really where we have payment models outside of just purely transactional fee-for-service. And where those come together, we call value-based care, where a value-based contract, population health views of health differences, where they come together, those Venn diagrams, that's what we call value-based care. And we use that as a working definition on the healthcare delivery side so that we can partner and have a little more of a shared common language.
Can you drill down specifically to why value-based care matters for population health?
Yeah, that's one that's, I think, a core question of U.S. healthcare. So, we live in a predominantly, UW Medicine is no different than many, many other healthcare delivery organizations across the state, across the country. The United States has chosen a model that is really based on different kinds of insurance, oftentimes employer-based. There are governmental insurance programs. In fact, the largest ones like Medicare and Medicaid are government, but we're mainly driven from a financial perspective by employer-based or commercial insurance. And we've paid historically on a fee-for-service basis, which is very transactional and very much where a patient comes in for a service, and then we deliver that service, we get paid for that service, the patient moves on, and there's no necessarily attached outcome-based parts of that. There's not necessarily even a service or quality-based part of it. When it was first instituted here, now 100 years ago, as we evolve from more of a community-based healthcare to a more formalized insurance transactional healthcare system, we started to realize that it was driving costs and procedures, but not necessarily delivering health outcomes to our community. I know this audience more than most know that the United States lifespan, which we could argue life expectancy, is a pretty solid measure of how we're doing as a community. The United States in the 1980s was within the pack of the OECD, the other economically developed countries. We were within the pack of that, below median, but still within the pack. And then every decade since there, we've fallen to now by far the worst country within the economically developed comparator countries. And value-based care has become more and more important over time because it's a way of looking at evolving our payment models. It's not the be-all, end-all. I think value-based care can also mean different things to different folks. But the way we define it as payment for anything in addition to just that transaction. So it could be quality-based payments, it could be experience-based, it could be cost-based for populations of patients, and how do we better align incentives in that so that we can both address health outcomes better as a population and as a country, and then realign health systems which are perfectly designed to optimize fee-for-service healthcare over the years, and then many organizations like UW Medicine that are very mission-based, trying to figure out how we can develop payment models that help to fund the kind of programs that we just heard from our fantastic prior speakers, around food security and those things that aren't just sick care, but the drivers of health outcomes for populations.
The words "in an era of uncertainty" are in the title of this talk. Can you talk about what is at stake as a society and as a set of our institutions right now, and how that relates to some of the work you're doing in population health?
Yeah, I guess I'll start. I'll try to start at a very high level and then work my way down into how UW Medicine is trying to work through a lot of the increasingly accelerated changes that were alluded to in the prior talks. At the maximum, sort of the macroeconomic level, and I'm probably, like, my core is probably an economist. Like, had behavioral economics been around when I was an undergraduate, I was an econ major as an undergraduate, I probably would have stayed an economist. I love trying to understand how people, societies, groups of people, societies sort of work their way through major problems and challenges. What I would say on the macroeconomic level is that our country is sort of spending ourselves into an unaffordable situation in healthcare. Healthcare in the United States, approximately 19% of our GDP, and the inflation rate of healthcare is faster growing than our GDP. So it's eating up a larger and larger portion of that gross domestic product of the United States over time. And what that means is that it's eating up money that could be used for education, could be used for food security, public health, improved quality of air and food, and other initiatives. And it's eating away at those things as part of healthcare without getting better results than countries who spend less of their gross domestic product on this. And so that's unaffordable. When our country continues to grow and our GDP is growing, you can kind of mitigate a little bit for that. If we ever hit a downturn, healthcare, and I think we're starting to see this now, healthcare and Medicaid, to be specific, at the federal level, is being looked at as one of the few areas that you can potentially cut expenses. Not right or wrong, just saying that there are programs that you could start cutting healthcare, which unfortunately for the United States will affect disproportionately certain patients and populations that depend on Medicaid, for example, for a lot of paying for healthcare. And so I think the area of uncertainty now getting down to the UW Medicine level, we're a healthcare delivery system that works across King County, but many of our specialty parts of UW Medicine, including Harborview and UW Medical Center, we have referrals from across the country for our specialty services. That could be bone marrow transplants through the Fred Hutchinson, trauma, level 1 trauma that Harborview gets across broad regions as being one of the few areas that can manage that. And locally, we have to balance those same challenges that every organization in the United States has to deal with in regards to trying to make sure that we can continue to fund the core resources, like keep our emergency rooms open, keep our staff paid and able to be healthy and stay at work. And we struggle with what sometimes we refer to as payer mix. Right now, commercial insurance programs pay 3 times as much as oftentimes governmental programs do. And so to keep the current level of expense in the current healthcare model and the way we're paid, we have to make some challenging trade-offs in there. Those trade-offs, if we have expectations over time, we can make slowly, thoughtfully. But when it comes all of a sudden, and I'll say the current administration has made a lot of very rapid changes. I still can't believe it's only been 100 days that the new administration has been in place. But both on the academic side, working on the sort of grants that help support some of our studying how our clinical work is effective, these anticipated potential cuts for programs like Medicaid and potentially even Medicare. We have to try to adjust our healthcare system to meet the needs of our patients and community. And again, being in a very mission-oriented organization, we want to be able to do that, but we also need to have that financial sustainability to keep the lights on, to keep the trauma room open, and the ability to take care of patients, burn unit and those. And so, that's an ongoing challenge. And we believe that value-based care is an important modality to try to balance that out a little bit. Because if we can get paid for outcomes, especially as the state's healthcare system, we have an accountability above and beyond just healthcare delivery or sick care. We also support a lot of community programs, public district hospitals, critical access hospitals across the state of Washington. And how to sustain those programs, those don't get paid for by fee-for-service. They just can't cover the cost of this. Value-based programs and population-based programs allow us to start to be a little more imaginative and I think be a little more innovative in how we deliver care, not just for our patients that we see here in King County, but also those that we support across the state of Washington and broadly even the WWAMI regions that our students go out to.
Thank you. What is your level of optimism for the future of value-based care as a population health solution?
Fantastic question. I would say it varies day to day. This is a very challenging era because I think we're taking in a lot of potential changes. Not all of them have even come to bear yet. And so we're anticipating, trying to get a little bit ahead of this. Healthcare is sometimes we call a high consequence industry, right? Like aviation, like police and fire, because, subtle changes can really affect the end product of what we do. If a patient comes into the emergency room with a trauma and we, for whatever reason, change something that doesn't allow us to have the right access to a trauma surgeon and to life support and to, the right products that they need for blood or other things, we could fail catastrophically on a patient-by-patient or even a population basis. And so as a high-consequence industry, I think that we're very cautious with change, and I think appropriately so on the care delivery side. That being said, your question is about optimism, and we have to mitigate these changes that we'd like to do probably innately in a slower, more thoughtful, research-based sharing with, the School of Public Health and the School of Social Work and the School of Pharmacy and the School of Nursing, trying to thoughtfully navigate through these complex health systems. But what I'll say is that disruption is also a big opportunity for us. And I just returned from a meeting in Baltimore through the National Association of ACOs. It's a group that's really focused on enhancing and sharing learnings from groups that are trying to make this value-based payment models, value-based care, a reality in the United States. And I would say that actually I was a little surprised that myself and my colleagues there had a pretty good sense of optimism coming out of all of these rapid changes that are happening. And part of this is because we also see that the way things were before weren't working well for our populations. Like I mentioned, even just life expectancy or infant mortality or maternal mortality, all have been getting worse over time relative to peers and international peers. And so we're also optimistic that some of these changes, and we actually had the chief operating officer, the new chief operating officer under the current administration, who will be working with Dr. Oz as the head of CMS, spend over an hour answering question and answers with this large session representing 600 organizations, including University of Washington, UW Medicine. And I came out of that thinking that, value-based outcomes, getting better outcomes for our community really is a bipartisan issue. And I do believe that the current administration, though philosophically has a lot of differences between the ways that the prior administration has approached it, still want that same end goal. And I came out more optimistic actually coming out of last week, which I didn't expect. Because my colleagues and I really said this is a good opportunity for us to challenge the status quo and to really think about how safely we can continue to evolve, but maybe put a little more of a burning platform to see how we can do it better and faster and help to address important health issues that we haven't been over the last couple of decades.
So I love this framing of opportunities. Hold that for a moment. We train hospital administrators. We train people who work in health informatics. We train public health practitioners, population health scientists, health services researchers. How should that large group of students and scientists like us who are working in the field be thinking about opportunity in this moment that feels very stressful?
Again, fantastic. For the University of Washington, we have so many people who are incredibly talented, intelligent, passionate, coming in with this uncertain future. I'll harken back to about a month or maybe 6 weeks ago. I gave a talk at the School of Public Health. The faculty member asked me, said, well, do you have a sense of optimism for this? And how can you convey that to the students that are, again, like students in the School of Public Health and many other schools across the University of Washington, going into an uncertain future for funding and other things in there? There was two speakers, and she and I kind of collaborated before the talk, and we both said, boy, we really feel that this cohort of learners, trainers, students, and we're lifelong learners, really have a big advantage over, I think, prior generations like mine. I trained in a biophysical model of healthcare. I learned all about physiology and Krebs cycle like 15 times. But then in my infectious disease training and epidemiology, I learned about all of the different curves, antibiotics, disease states, testing, and all of those things. What I didn't learn about were social drivers of health. What I didn't learn about was improving metrics around how do we evaluate the outcomes of what we do. It was kind of, as a physician, and I was mostly in clinical practice earlier in my career, I judged my practice with just how I thought it was. And patients, were either satisfied or not. They either come or go, but there wasn't any native feedback mechanism. I think that the learners today are way, way more sophisticated and understand the complexity of the problem much better than, I would say, my generation of trainees coming out into the world. And I think that, for the next generation, I think that the problems are more clear and the burning platform is more apparent. And I think it will drive changes in a much more rapid way. And I think that the impact of folks going into health administration or informatics or these has the real possibility of making meaningful changes and improving clinical value, if you define that by quality outcomes, experience of the patients and populations over the net cost to deliver. I think that there's a real chance that we are at a point where we're either going to have to fish or cut bait, give up, which I don't think is anyone's option, and really instead leverage on the passions. But I think that one of the keys to doing that are going to be these cross collaborations. Like the School of Pharmacy isn't going to do it by themselves. The School of Dentistry isn't going to do it by themselves. The School of Medicine, the School of Public Health aren't going to do it by ourselves. Never. I think that healthcare is too complicated and much more of a team sport. And we're going to have to figure out ways to do it better together. And I think that's my great sense of optimism. I think we have groups coming out that are more aware and smarter than certainly I was. And I think we'll need to help create the organizational framework to create better collaborations. Maybe this type of venue being one of those bridges that we can build.
Thank you. Okay, I have one last nerdy question for you. So you're trained as an infectious disease, you're a practicing infectious disease epidemiologist and have been responsible for responding to HIV, Ebola, H1N1, COVID-19 lately. How do you think about those lessons in terms of us being better equipped to rapidly evolve in this changing climate?
Oh my gosh. Really, that is, I think, one of the key questions we need to help address as in healthcare delivery for sure. So I'll go back to HIV. HIV affected a lot of people, but was rapidly sort of identified as affecting a lot of disenfranchised populations across. And I would say that, I've also, just truth in lending, I've been a board member of Lifelong, used to be known as Lifelong AIDS Alliance, which is a collaboration of a lot of different groups that started here in the Puget Sound area to respond to the HIV/AIDS epidemic. That was my first pandemic, and it was during my training years. But what was interesting is that the Chicken Soup Brigade, talking about food insecurities, the Chicken Soup Brigade formed with little tin cans collecting. People put in money, and then people went to people's homes who were suffering before we had adequate treatments for HIV/AIDS for people who were wasting away. And that was food security, at that time. And that was amazing to see communities come together, and that informed why I went into infectious disease. I said, and me and probably a lot of my cohorts that trained during the HIV/AIDS era, we sort of saw two groups. One that was like, oh, I don't want to do that. That's too scary because there's so much unknown. And then people who ran towards the fire. And I said, okay, that's hopefully who I aspire to be, running towards the fire. So that first pandemic, I think, really showed what community action can do when focused appropriately. And I'll fast forward to the COVID pandemic. I did mention that healthcare is one of these high consequence industries that sometimes I think we use as a foil for innovation and change. And when I say that, I don't think in any kind of intentionally negative way, but I do think that sometimes we're too scared to innovate because we are worried that we'll break something that, on how we care for certain patients, as they address our health system. What COVID taught us is that with a shared common challenge that we had. There was a lot of unknown, just like at the beginning of the HIV/AIDS pandemic. There was a lot of unknowns, a lot of fear, but healthcare organizations and all of the supporting schools and others across UW Medicine, also knowing that we were not only the subject matter experts and healthcare delivery, we were also a potential consequence of getting COVID. Like, my wife and I, when we first started, I was helping to lead a COVID response for a large healthcare system that wasn't UW Medicine. But, I slept in a different, whole different area in my house when I came back because I was rounding in areas where we were taking care of patients who, had COVID-19. And I think that burning platform helped us to know and really appreciate that we can together thoughtfully move much more quickly than we've thought ever in the past. And the way we rolled out vaccines and the way we rolled out other, testing, vaccines, I think is really a model of how we can thoughtfully and more rapidly innovate and change. And it's what's that burning platform for us going forward, And I feel like value-based care, even though it's been around for a long time, is really one of those things that might be able to be a rally point around which we can innovate together.
Thank you so much, Dr. Myint. That was great.